Hello all, welcome to Medical YouTube channel. Today I shall go through 100 one-liners on MASLD from anatomy to medicine. Let's start with the first question. What is the new name for MASLD? MASLD, metabolic dysfunction associated steatotic liver disease. Why was the old term NAFLD replaced? Because it was diagnosed by exclusion of alcohol. And MASLD is defined as what core hepatic abnormality? It means more than 5%. MASLD requires steatosis plus what additional criterion? One or more than one cardiometabolic risk factors. These are the cardiometabolic risk factors: overweight, obesity, high blood sugar, hypertension, high triglycerides, low HDL cholesterol. So for formal diagnosis, you need a hepatic steatosis more than 5% or 5 or more than 5%, and at least one of these cardiometabolic risk factors. And yeah, you should have a less than 20 gram per day alcohol for women and less than 30 gram a day for men. Next, what do you call inflammatory progressive form of MASLD? MASLD is just fat accumulation in liver. But what happens if you include inflammation? You get steatohepatitis, fat plus inflammation. What is the term for fatty liver with both metabolic risk factor and moderate alcohol intake? MET-ALD, metabolic dysfunction associated alcohol liver disease. Why is MASLD classified as a spectrum disorder? Because it ranges from steatosis to cirrhosis. Which is the single most important etiologic mechanism? Insulin resistance. Which pathway becomes insulin resistant in the liver? The gluconeogenesis pathway, mediated by a FOX1 transcription factor. Which pathway remains insulin sensitive despite systemic resistance? The lipogenesis pathway, mediated by SREBP1C transcription factor. This concept called as selective resistance, where there is resistance to one pathway and sensitiveness towards another pathway. Like example here, gluconeogenesis, it's resistant, and for lipogenesis it's sensitive. So patient will have both hyperglycemia and hypertriglyceridemia. How does insulin resistance affect adipose tissue lipolysis? It fails to suppress hormone sensitive lipase, leading to uncontrolled release of fatty acid. And also, what is the primary source of excess fat in MASLD? That is adipose tissue. So your main source is adipose tissue. So after lipolysis, you get fat in liver. This is how hormone sensitive lipase acts. Since there is less insulin action, the more glucagon and more epinephrine will dominate over insulin, which leads to triglyceride breakdown and more free fatty acid and glycerol. How does insulin resistance stimulate de novo lipogenesis? Like already said, adipose tissue lipolysis was the primary source for MASLD. The second source is de novo lipogenesis. How does it mediate it? We already discussed this answer. It's through SREBP1C by stimulating this transcription factor. this pictorial representation of whatever I explained so far. We have insulin inhibiting hormones into lipase, so there is more breakdown of triglycerol to fatty acid and glycerol, and insulin also stimulating SREBP pathway. Next, fat accumulation causes hepatocyte injury mainly via, so like I said, from adipose tissue we have free fatty acid coming to liver, then we have de novo lipogenesis. So how this all this fat getting accumulated, how does it cause injury? Through lipotoxicity such as toxic FFAs and ceramides. And this lipotoxicity primarily damages which organelle? Mitochondria. And the mitochondrial dysfunction leads to impaired beta oxidation of fatty acids. And the impaired beta oxidation results in excess production of ROS. Guess right. And this generated ROS directly causes which cellular defect? Guess right, lipid peroxidation and membrane damage. Then the damaged hepatocyte release signals that activate which cells to start fibrosis? Which cells to start fibrosis? Hepatic stellate cells. Chronic inflammation in MASH is driven by which cytokines? Chronic inflammation and which cytokine? We should be answering by this right now. TNF alpha and interleukin 6. I have a separate video on interleukin 6. Please check out that in my playlist. And which disease has the strongest association with the MASH? Yes, type 2 diabetes. Both have insulin resistance. And what type of dyslipidemia pattern is seen in MASLD? Yes, hypertriglyceridemia with the low HDL. Rapid weight loss starvation can cause fatty liver. Why? Yes, adipose lipolysis. And another endocrine cause, Cushing syndrome, predisposes due to, yes, again insulin resistance due to cortisol induced. PCOS increases the risk of MASH through insulin resistance. Hypothyroidism, another endocrine cause, predisposes by causing reduced lipid metabolism. And in further slides we shall be dealing one of the drug, resmetirom. It is a THR beta, and THR is a thyroid hormone receptor. There are two types, alpha and beta, and alpha is present in heart and bone, which on stimulation causes tachycardia, and beta is predominant isoform in liver. It is responsible for hormones, metabolic and lipid lowering effects. So we shall be seeing that in future. And one of the association with MASH is OSA, and OSA worsens MASLD via intermittent hypoxia and metabolic stress. How exactly? Like with OSA causes repeated cycles of low oxygen, that is hypoxia, followed by reoxygenation. This activates HIF1 alpha. It's called as hypoxia inducible factor 1 alpha, and it is lipogenic. It stimulates lipogenic genes in the liver. And one more is due to oxidative stress, that is the reoxygenation phase. It's acts like a reperfusion injury, generating reactive oxygen species that damages hepatocyte mitochondria. And there is sympathetic overactivity. OSA induced stress increases catecholamines, which worsen insulin resistance and hepatic glucose production. And one more term you should know is what is lean MASLD. MASLD occurring in individuals with a normal BMI, often due to high visceral fat or genetics. And there's a term called as TOFI, So, toffee means thin outside and fat inside. They are mainly talking about visceral fat. And speaking of genetics, which genetic variant has strongly implicated in MASLD? PNPLA3 mutation. And please comment on which genetic gene variant has protective role in MASLD. And which iron related condition can mimic or exacerbate MASH? Hereditary hemochromatosis. Which dietary sugar is most strongly linked to de novo lipogenesis? Fructose. Fructose stimulates de novo lipogenesis independent of insulin. And a term for cirrhosis where original fat and inflammation have disappeared, making the etiology hard to find. Previously, they used to call this COP in cirrhosis. Now it is termed as burned out MASH. Single most important histologic feature distinguishing MASH from simple steatosis. Hepatocyte ballooning. This is a image of hepatocyte ballooning. And what type of steatosis is classically seen in this MASLD? Macrovesicular and microvesicular for smaller extent. This image, left side there is microvesicular steatosis and right one is showing macrovesicular steatosis. This is very historical staging, but it's good to know the name. Brand criteria. And this stain which identifies the collapse of liver framework and presence of regenerative nodules. Name the stain. Reticulin stain. And this image of reticulin stain. And you should know the difference between reticulin and MASLD trichrome. Both stains what? Your reticulin stains type 3 collagen and MASLD trichrome stains type 1 collagen. And the main role of reticulin is for to see the architecture, and for MASLD trichrome the main role is for fibrosis quantification. Mammary lung bodies are composed of, I know you know this, you can answer, cytokeratin intermediate filaments 8 and 18. These are cytoplasmic inclusion found within hepatocytes that have undergone injury and ballooning. Which is the earliest site of fibrosis deposition? Perisinusoidal zone 3. You can see zone 3 in the left image, and on the right there is sinusoid and perisinusoidal space, the space of Dissay. That is where fibrosis first starts. What is the classic description of early fibrosis pattern? Chicken wire fibrosis. Name the stain used here. Please comment down. Special stain best to highlight fibrosis. MASLD trichrome. So you don't have to comment down for previous question. So take a screenshot of this. It is stains for all connective tissue. We have MASLD trichrome, Van Giesen, PTH, HND. So how do each connective tissue looks under each stain? Please take a screenshot and have it will come in handy. Which is the cell responsible for collagen production in fibrosis? We've already discussed hepatic stellate cell. And where is it present? Space of Dissay. What do you mean by bridging fibrosis? Fibrosis between portal or portal central areas, and it's most commonly seen in F3 stage of fibrosis. Coming to clinical features, right upper quadrant pain is caused by capsular stretching. What is the capsule of liver called as? Anatomy. Yes, Gleason capsule. Which is the most commonly reported symptom? No, it's not right upper quadrant pain. It's fatigue. What is the hallmark clinical phenotype in over 80% of cases? Yeah, it's easy. Central obesity. It's also called as android obesity. This image of showing android and gynoid obesity. Android obesity is also called as apple obesity, whereas gynoid is called pear obesity. Oh, this you must all know. Yes, acanthosis nigricans. Easy. Next. They are strong kidneys markers for metabolic syndrome and insulin resistance. What are acrocodons? They are another name for skin tags. Yeah, I know you diagnosed already. Yes, it's a type of xanthoma, but when in eye it is called as xanthelasma. A palpable spleen in MASLD patient suggests what? Yeah, it's one of the easiest answer. Yes, portal hypertension. How does portal vein is formed? Which liver enzyme is typically higher in MASLD? ALT or AST? Yes, ALT. And when does this ratio flip? When as the disease progress, the AST keeps on increasing and AST keeps on accumulating in body. Coming to tests, which lab-based fibrosis score is first-line screening? FIB4. FIB4 uses which four parameters? Age, AST, ALT, and platelets. What is the formula? Please comment down. What is the classic USG appearance of fatty liver? It's easy. The increased hepatic echogenicity. And how does it look in non-contrast CT? Yeah, it is hyperdense, darker. The image is showing Hounsfield units of each: air, water, air, fat, water, CSF, white matter, gray matter, blood, calcium, metal. And fat is at the darker end, -100. And which is the most accurate technique to quantify liver fat? MRI, PDFF. What does PDFF stands for? Proton density fat fraction. And it's superior to biopsy. And why is it superior? Because it assesses entire liver, unlike biopsy where you assess only one of 50,000th of organ. And we have MR elastography. And how is it superior or better from MRI? You can measure liver stiffness, not just fat content. What does VCTE stand for in liver diagnostic? Actually, you know the common name for VCTE, but I think you don't know what VCTE stands for. It stands for vibration control transient elastography, commonly called as fibroscan. I know you would have heard of fibroscan. And in fibroscan there are two parameters, CAP and LSM, that is measured. And what does CAP stands for? What does it measure? It stands for control attenuation parameter and measures steatosis. And how does liver stiffness measured? LSM measures fibrosis and in kilopascals. So LSM more than how much is cirrhosis? Usually more than 12.5 to 14 kilopascals. Then one of the risk complication of MASLD MASH is hepatocellular carcinoma. And what should be the, when should you do ultrasound, how often to screen for HCC? Every 6 months. And one of the scoring system, NFS, it includes BMI and albumin. Another scoring, ELF, stands for enhanced liver fibrosis score, and it measures matrix turnover markers. And which is the marker? Procollagen 3 amino terminal peptide. Now coming to treatment part, which is the most effective drug-free treatment for reversing MASH? Drug-free, yes, weight loss. And for 5% weight loss, steatosis improves, and for 7 to 10% inflammation improves, that is steatohepatitis improves, and more than 10% weight loss, there is fibrosis regression. Speaking of weight loss, there is Mediterranean diet, a type of diet known as Mediterranean diet. And what is its role? It is where more of vegan diet, where patient is asked to eat more of nuts, vegetables, and seafood rather than meat. And also read about Newcastle diet and what is the calorie limit in Newcastle diet. Now coming to drug proper, apart from weight loss, resmetirom. I've already told about this while I was speaking on hypothyroidism, so I hope you answer now. So what is mechanism of action? It's a THR beta. Like I said, THR alpha is in heart and bones, and THR beta is in liver. And which vitamin is recommended for non-diabetic patient with biopsy proven MASH? You can try. It's an antioxidant vitamin. Yes, vitamin E. Which thiazolidinedione is used for MASH in diabetic patients? Name a thiazolidinedione that you know. You'll be right. Yes, pioglitazone. And how do they act? They are PPR gamma agonist that redistribute fat from liver muscle to peripheral adipose tissue. And there are, we just saw PPR gamma. Then there are PPR alpha, gamma, delta agonists such as lanifibranor. And what is the role of GLP-1 receptor agonist? Semaglutide. Yes, you would have heard of semaglutide, right? Whenever obesity topic comes, semaglutide will always be there. Yes, it has significant weight loss effect. And a drug with both GLP-1 and GIP, tirzepatide action. Tirzepatide has both GLP-1 and GIP receptor agonist, so it's even better than semaglutide. Obeticholic acid. What is obeticholic acid? It is FXR agonist. What is FXR? Farsinoid X receptor. And when do we ask patient for bariatric surgery? since the weight loss is not happening. We have to tell at what BMI. So if they are 40 or more than 35 with comorbidity. And what is the most common cause of death in these patients? No, it's not cirrhosis. It's nothing to do with liver. It's more of cardiovascular disease. People die of MI. One thing I forgot to tell you, even though the dyslipidemia pattern is high triglyceride and low HDL, the HDL, low or normal HDL, the HDL present is small dense lipoprotein LDL, small dense LDL, which is worse. It is very atherogenic. So statins are also given, and statins give cardioprotective action. Thank you.